All right, let's talk about something that is absolutely 100% going to show up on your boards: pulmonary embolism. This is one of those topics you just have to know inside and out. So today we're going to break it down with a super high-yield, step-by-step approach. Let's get right into it.
Okay, so picture this, because you know this question stem is coming. You've got a patient. They're suddenly gasping for air, clutching their chest. Your brain is firing off a dozen possibilities, but PE is screaming at the top of the list. The real question isn't what it could be, it's what do you do right now? What's the process?
So let's just ground ourselves in the basics for a quick sec. What exactly is a PE? You can think of it like a plumbing problem, really. A clot, usually from a deep vein in the leg, a DVT, breaks loose, takes a trip through the heart, and then, bam, gets stuck in the pulmonary artery. And this illustration shows you exactly what I'm talking about. See that? That clot is like a roadblock on a major highway. It's blocking blood from getting from the right side of the heart to the lungs to pick up oxygen. And that blockage, that's what causes all the chaos, the low oxygen and the strain on the heart that makes PEs so deadly.
Now, before we even think about ordering a single test, we have to think about risk. Does this patient's story fit? We're talking Virchow's triad here. So look for those big clues in their history. Do they just have surgery? Have they been stuck on a 12-hour flight? Do they have cancer? Maybe a family history of something like Factor V Leiden? Or are they on oral contraceptives? These are all major red flags that should make you lean in.
Okay, so you're suspicious. Now you need a system. On your boards, you can't just guess or order a bunch of random tests. You need a validated algorithm, a step-by-step process that guides you. This is how you get the points, and more importantly, this is how you get it right in the real world.
And your first move, your step one, is to formalize that suspicion with the Wells score. Now look at how this is weighted. This is key. The two heaviest hitters, worth 3 points each, are seeing signs of a DVT. You know, that swollen, painful leg, and your own clinical gut feeling that PE is the #1 diagnosis. Everything else adds up, but those two, those are the big ones.
And here it is. This is the magic number. The entire algorithm, everything you're about to do, hinges on this one number. Is the Wells score greater than 4? This is the gatekeeper for the whole workup.
So here's the fork in the road. It's super simple. If that score is greater than 4, their risk is high. You don't mess around. You go straight to the definitive test, the CT pulmonary angiogram. But if the score is 4 or less, their risk is low. And this is where you use the D-dimer. Think of the D-dimer as a rule-out test. If it's negative in a low-risk patient, you're done. No PE. Okay, let's get into the good stuff. Let's talk about the classic exam traps. These are the little details that test writers love to throw in to see if you're really thinking, not just memorizing.
This is a massive one. Seriously, burn this into your brain. The question will describe a patient who is just screaming PE, and then they'll casually mention, oh, by the way, the chest x-ray is totally normal. That's not a reason to back off your diagnosis. It's a reason to be more suspicious. The most common finding on a chest x-ray and a PE is a normal chest x-ray. And here's the other classic triad you have got to remember. You have a patient who is short of breath, their oxygen is low, but you listen to their lungs and they sound perfectly clear. No crackles, no wheezes. Your PE alarm bells should be going off like crazy. Why? Because the problem isn't in the lungs themselves. It's in the pipes, the blood vessels.
All right, you've navigated the diagnostic maze, you've confirmed the PE, now what? Well, the management plan is actually even more straightforward. It all comes down to one simple, critical question. Is your patient stable or are they unstable?
And this slide right here is the whole ballgame. This is the decision. If your patient is unstable, we're talking low blood pressure, they're confused, that means it's a massive PE. It's causing shock. You don't have time to waste. You have to bust that clot right now with thrombolysis. But for almost everyone else, the vast majority of patients who are stable with normal vitals, the treatment is anticoagulation. We just want to stop that clot from getting any bigger.
So let's dig into that much more common scenario, the stable patient. You've decided to anticoagulate, but with what? The boards will definitely expect you to know the different flavors and when to pick each one.
Think of this table as your playbook. For that really sick patient in the ICU, you're probably going to use an IV heparin drip. Why? Because you can shut it off in a second if they need a procedure. For your standard patient on the floor, or importantly, for a pregnant patient, low molecular weight heparin is a fantastic choice. And for a lot of stable patients now, especially those going home, the direct oral anticoagulants, the DOACs, are the way to go.
And how long do they stay on this stuff?
Well, the rule of thumb is pretty logical. If the PE was provoked, meaning it happened because of something specific, like that recent surgery, you'll treat for about 3 to 6 months. But if it was unprovoked, meaning it just kind of happened out of the blue, you're going to treat for longer, maybe 6 to 12 months, and sometimes even for life.
Whew, okay. We've covered a ton of ground. So let's boil it all down to the absolute must-knows. What's the final mantra you need to walk into your exam with?
This is it. This is the whole thing in a nutshell. If you suspect a PE and the patient looks sick, you treat first. Don't wait. The core principles are always, number 1, stabilize the patient. Number 2, get them on the right anticoagulation. And number 3, once the fire is out, you have to go back and figure out what caused it.
And that leads us to our final, really important question. The job isn't done just because the clot is treated. That last step, searching for the cause, is what separates good from great. Are you going to look for a DVT in the legs? Are you going to think about a deeper workup for a clotting disorder or even an underlying cancer? Thinking about these next steps, that's how you show you've truly mastered this topic.